All right,
So, hi
good.
everyone. My name is Abrar, and myself and my team, represented here by Rataj, are really happy to welcome you all to yet another neurosurgical anatomy talk. We are pleased to be joined by Dr. Rebchuk of the University of British Columbia, who's graciously agreed to present his talk on neurovascular anatomy. Dr. Rebchuk, whenever you're ready, the floor is yours.
Sweet. Okay. Thanks for having me, guys. I did this talk, I think, last year, and it was pretty helpful, or hopefully it was pretty helpful. Um, so my name's Alex. I am the fourth year resident here at UBC. And I'll present a bit of neurovascular anatomy, I think, and I kind of said the same thing last year, but this is all stuff that would be maybe not expected, but would be pretty close to the level of a rotating kind of fourth year student interested in neurosurgery. So um, it's up to you. I mean, it can be interactive or it can be quite dry. So if you guys feel free, I'll have some questions, and if you know the answers, you can kind of shout them out, or um, otherwise, you can just try to figure them out yourselves. So these are kind of all the it's predominantly a lot of questions, but all these would be pretty fair game to ask somebody who's rotating on an elective in fourth year applying to neurosurgery. I presume most people here are applying to neurosurgery. And then at the end, we can kind of chat about electives if anybody has any questions. Should I sort this out? If I can get my slides to work. No. Sorry, one second. How do I get that's better. Okay, we'll try to get through all this. We'll keep it short. We'll keep it under 45 minutes. So this is the aortic arch. So I mean, this is a common picture from medical school. So I mean, it's a few people, but if anybody knows, you can shout out the answers. If not, we can just slowly go through it. I'll give you about like 15 seconds to kind of think your way through it. But if anybody knows, they can just answer along. Anybody? Number one. I'll go through it, but this would be, I mean, this is stuff that, and it's something that, I mean, this is all pretty fair game. It's the first one, and this is all what you should know. So the vertebral artery, if you got that, you're going to see this is going to be the carotid. So this is, again, the innominate artery of the brachiocephalic and its branches there. The left carotid being there. Again, you'll have the vert, subclavian, innominate or brachiocephalic trunk there. And then the right subclavian. So again, somebody put in the chat. Nice. Okay, somebody's in the chat. Devane, soft neck. Okay. Another picture. I mean, I find with all these, it's kind of helpful to have a look at these from multiple angles. So number one, what's it pointing to? I think it's pointing to this over here. Does anybody know? Oh, the vagus nerve. Number two, anybody know? So again, that's going to be the common carotid. So three on the other side. We think about common carotid. We'll go through this in a bit faster, but the vagus, and then does anybody know the nerve branching down from over the heart? Oh, sorry, subclavian, and then the phrenic. So both phrenic nerves going to supply the diaphragm. Nice, the vein, 2 for 2. This is another question, and I mean, when you think about this, and the point of this lecture is to highlight what you guys should know. So if you don't know the answer for these, this is something you can go and stare at the textbooks and learn yourselves. But another common question being the branches of the external carotid. So there's a bunch of named branches, and there's mnemonic for these. Does anybody know what any of these would be? Or what this mnemonic is for the external carotid? That's fine. So I'll go through these, but these are all the branches here. So superior thyroid, ascending laryngeal, lingual, facial, posterior auricular, occipital, maxillary, superior temporal. So the mnemonic for this being superior ascending, or pardon me, some anatomists like freaking out poor medical students. So those are the branches from ascending. So the superior thyroid being the first branch of the ECA, all the way up to the STA being the most distal branch. So if this is something you haven't heard of, you should learn this, as this would be, I mean, this is stuff that this kind of level of knowledge is stuff that we would expect even from students not really rotating through neurosurgery. This is something that would have been covered by all your core curriculums. So again, knowing these branches and not necessarily being able to, the image is here for reference, but not being able to necessarily sort them out on the image, but certainly knowing all the branches and knowing, like I said, a mnemonic for them. So some anatomists like freaking out poor medical students. So when I was in Dalhousie, I was doing this case, so a carotid endarterectomy, and this is the anatomy of a carotid endarterectomy. And this is kind of the classic view you'll get after the exposure. So I was helping one of the staff in Dalhousie with this case, and this was kind of what was asked of me, is what all these branches were, and they had labeled them. So we can go through them kind of one by one, but does anybody know what side we're on? So it's either the right or the left. Anybody? So the right side, you can see that. So this is the common carotid, obviously here, and then you'll see here there's two ways to sort this out, and we'll go through what they are. But common carotid, so this is down at this end. So the left side of your picture is going to be kind of towards the feet, and the right side is going to be towards the head. So the big red thing in the middle is obviously the common carotid, and then it branches, divides here into the internal and external carotid. The ways to sort this out is if you're looking at this and you don't know where to start, is that the external carotid is going to have extracranial branches. So you can see here the superior thyroid branch coming off. So even if you don't know it's the superior thyroid, you should know that there's branches of the external carotid artery that are extracranial. So that's the way of sorting this out. So this is the ECA, and it's going to be the ICA. So, oops, we don't have them. So I can go ahead and go through them, but this will be superior thyroid. Like we said, the common carotid, the external carotid, the internal carotid. The crossing, this is carotid bulb is what I think it's highlighted here. The crossing vein is something that comes up a lot. So the facial vein crosses. So this can be sacrificed, but that's kind of one of the large veins you'll see. The jugular vein is the blue thing here, which again, you don't always see and not always as prominent. And then the vagus nerve is the nerve that runs in the carotid sheath. So this yellow structure is the vagus nerve, and it often sits posteriorly, so you don't always see it. Things to know about the carotid artery: it bifurcates between C3 and C5. So that's often just between the hyoid bone and the upper border of the thyroid. There's multiple classification schemas. The one you guys will most likely be familiar with is Boutelier, and we'll go over that. But you can see here there's a bunch of people who have classified it, and it may have been taught different ways. The most common one, especially in cerebrovascular neurosurgeries, is Boutelier. That's what you should have a pretty good grasp of. These are the anatomical segments. So you might have been taught this or seen this before. So there's the cervical ICA, so that's extracranial. The ICA then runs within the petrous bone. It's called the petrous part, then runs within the cavernous sinus, so-called the cavernous segment, and then the intracranial segment, so the cerebral part. That's the more straightforward classification. The Boutelier is one that's more frequently used and is a bit more descriptive. You may have seen this before, but this is kind of the classic diagram of it, and these are the segments. So being able to rattle these off is, again, something else if you don't know this or haven't heard of this, I would read it. But being able to rattle off a few of these segments, and they're all named for where they are. So the cervical being within the cervical carotid, petrous and the petrous bone. The last one, this foramen here that the cervical, the ICA runs within, is called foramen lastrum. So that's that segment. Cavernous segment named for the cavernous sinus. Clinoidal, so the anterior clinoid is what it runs around. So again, named for the kind of the relevant anatomy. The ophthalmic segment or the supraclinoidal segments, and that comes up to the communicating or terminal segments. So if you haven't heard of these, it's called the Boutelier segment, and this is a bit more descriptive and kind of within neurovascular or cerebrovascular neurosurgery, kind of the more commonly used segments. I won't go through all of these, but you can see here, and we'll get to this at the end, is being able to recognize these on angiogram as well. Circle Willis, something you hopefully all have at least have heard of before, but something, again, you should know. It's named after Thomas Willis, who described it here in this kind of original drawing. It allows kind of a redundant supply, arterial supply to the brain, and allows for redundancy in that cerebral circulation. So there's multiple connections that allow kind of anterior to posterior circulation connection and left to right circulation connection. This is kind of the classic diagram. I will slowly go through it, but I'll give you a second to kind of think about it. And this is a fourth year med student, I think, on a stroke service in one of my electives. I rotated on stroke, and I was asked to actually draw this on the board, just replicate this diagram. So again, if you can't or have never seen this before, you should learn it. But this is, again, I was asked to do that as a fourth year med student. So the first one, it's kind of quiet, I'll just go through it. But the first one would be the PCAs. You can see here, so this is the ICA, so the branch going out lateral is going to be the MCA. Connecting these two here, so these are going to be the ACAs, and connecting them to the ACOM, or the anterior communicating. The ACAs go out within the frontal lobe. On the contralateral side, connecting the anterior to posterior circulation is the PCOM. The SCA is going to run right here, so between and I mean, this will come up, but between this PCA and the SCA, so within this gap here, the ocular motor nerve runs. So with a PCOM aneurysm, you can certainly get an ocular nerve palsy. 7 being the basilar artery. I think 8 disappeared. 9, ICA. 10, pica. 11 is going to be the vert, and 12 is going to be the anterior spinal. So this is, kind of a classic diagram, and it gives you, it doesn't really look much like this in vivo, but this gives you an understanding of how of all the connections. And there's a lot of variance to this that you'll learn over time, but being able to reproduce this diagram as a fourth year medical student would certainly be expected knowledge. And you can see here when he starts getting into cadaveric dissections, and it doesn't look as clean. And I think and why we kind of say you should be able to reproduce this is if you truly understand this and can reproduce this, you can start trying to apply it here. So if I can convince you there's the basilar artery here, you can kind of see the posterior cerebellar arteries going out laterally in the posterior circulation. You can see these connections here, so that being the PCOM connecting the anterior posterior circulation. Again, both ACAs running up towards the frontal lobe, the ACOM connecting those, and you can see the MCAs coming out laterally. But to be able to see that in vivo, you certainly need to be able to understand it in the schematic form. So this is what it starts to look like, and this is when it becomes a bit more challenging. So to sort it out intraoperatively. But does anybody know what number 1 is? I'll put it in the chat if you do. Wait. Any of them? So number 2, anybody? Or does anybody know what any of these are? 1, 2, 3, 4, 5, 6, or 7? So we'll go through it all, but this is where it becomes like, I mean, oops. This is what we ask kind of our first year residents to sort out, but being able to apply that picture of the circle of Willis and apply it to kind of surgical anatomy. So looking at, this is what it starts to look more like, and I mean, the brain stem's cut here, so there's brain stems removed, but this is becoming a bit more realistic about how to sort this stuff out. So 1, if you can, is going to be a P1 segment of the PCA. So these are the PCAs coming back around the brain stem. 2 is going to be connecting the anterior to posterior circulation. So that's the posterior communicating artery. This yellow thing below it is what I was talking about earlier. So that's the third nerve. That's why you get a third nerve palsy with a posterior communicating artery aneurysm. 3 being the MCA, 4 being the ACA, 5 is the contralateral ICA. So you can see this coming up here. So this is the cavernous to the supraclinoidal segment. 6, and I highlight this, it's a common question that we ask kind of our first year residents, but this would be the middle meningeal artery. So we're looking at, it's hard to do this virtually, but we're looking at the kind of above, looking down on the circle of Willis. So this is the floor of the middle fossa here that's been cut. And that's going to be foramen spinosum. So the middle meningeal artery, which give you an epidural hematoma. And then 7's being the other PCA. So I put this here, and there's a few of these diagrams, but it's really to show you that if you don't really understand the schematics or have a good understanding of how to sketch this on a piece of paper before you put in all the other anatomy, it's going to be quite challenging. And this is when you start seeing the intraoperative photos. This is sorting this out intraoperatively. You really have to have a thorough understanding. So that's why I kind of added these images here. I'll chat briefly about the MCA. There's 4 segments. So you may have heard them as M1, M2, M3, and M4. They're all named here. So the M1 being the sphenoidal segment, M2 the insular, M3 the opercular, and M4 the cortical segment. But they supply kind of this lateral aspect of the cerebral hemisphere, frontal-parietal temporal region. The big thing to note here is kind of this orange pie, and you'll see that if you look at CT scans and you see somebody with an MCA stroke, you'll see that will all be darkened or hypodense, pardon me. And that's indicative of an MCA stroke. These are just the divisions here. So another way of looking at this, you can see the ICA coming up to the horizontal segment or sphenoidal segment to the insular, opercular, and then cortical divisions. And you can see here all these lenticulostriate arteries coming off that horizontal or sphenoidal segments. And that's what I was talking about earlier. So looking at another classic image, and this came up a bunch during my 4th year electives, but being able to see this image and recognize this is somebody with a MCA infarct. So that's the MC territory. This is a multi-phase CTA showing the same thing. The ACA, 5 name segments, stuff that you should know. So again, A1, A2, A3, A4, A5. They're all names. Most people kind of go with the A1, A2, A3, A4 segments, but they do all have names. And it's certainly being able to recognize them. They're all named relative to their kind of relevant anatomy. So you can see here the horizontal segments coming out laterally. Then you'll have the vertical rise of the A2, followed by the precallosal. So in front of the corpus callosum, the supracallosal, and the postcallosal segments. The division between A4 and A5 is the coronal suture. And why all that matters is, again, you see all these in the textbooks and these kind of schematic diagrams. And then what we ask our residents and what, I mean, the medical students that excel on electives would be able to kind of sort all this out and seeing this image. So again, it's making sure you can recognize. And I think the way to approach these is, some of you probably are seeing these types of images for the first time, is trying to find something that's you can use to landmark yourself. So here you have the corpus callosum with the genu, so the beginning of the corpus callosum with the vessels wrapping around it. So that lets you sort out that the left side of this image is towards the eyes and the right side's towards the back of the head. And this is actually a bit challenging, but you can see here A1, or pardon me, number 1 is going to be the orbital-frontal branch. Then there's a frontal-polar branch, which is number 2. Coming around here is the pericallosal. Then you have the colossal marginal branch up here, and the pericallosal branch here. One of these, this is going to be A2, ACOM, and then Huebner's back here. But I think adding these here mostly for you to try to sort them out yourselves and quiz yourself of being able to look at this and figure out what your anatomy is quite key. Here's the schematic again. So this A1, A2, you can see how it wraps around. So A3, A4, A5 segments. The big one to recognize here is the recurrent artery of Huebner. So that's the largest perforating branch. It comes off kind of from the junction of A1 and A2 at that junction. And I'll just tell you what it supplies, but it supplies the head of the caudate, the anterior lenticuliform nuclei, and then the internal capsule. So it would be a debilitating infarct. Perfect. Yeah, so you can see here. So if you have contralateral weakness and dysarthria and potentially hemichoria, it can all result from an infarct of Huebner. You can see here, so Huebner is this large branch that they're demonstrating. It's quite variable where it's locating, but essentially it's the largest perforating or largest kind of lenticulostriate branch off the A1, A2 junction. And looking at this, again, this is subfrontal view, you can see it here. And I put a bunch of these in. So I tried to add a bunch of these Roton pictures, but they're certainly helpful for you guys to, I think in medical school, you look at a lot of kind of sketches and drawings and cartoons of the anatomy, but once you get into residency, you're going to see a lot more actual true anatomy, and it's being able to sort out kind of the 3D orientation. So when you look at this, it can be quite disorienting, and you're like, what am I looking at? And like I said, the key thing is to find something you know. So these are going to be the optic tracts. So this is going to be the chiasm. So now you can see the orbits are here. So now you have your orientation. So you can see here the ICA coming up to the MCA, to A2, or pardon me, A1, A2, running backwards. This large perforating vessel, this large, branch is going to be Humner, and the contralateral side as well. So ICA, MCA, A1, and then A2 running back. But it's being able to look at these and try to get oriented, which is key. This is, again, just if you see a MRI, this will be where the artery of Humner has an infarct. Okay, PCA, so terminal branch of the basilar artery, supplies the occipital lobes as well as the posterior and medial temporal lobes. There's 4 segments to the PCA: pre-communicating, post-communicating, quadreminal. So you may have heard of the quadreminal cistern. So the quadreminal segment runs within the quadreminal cistern, as well as the cortical division. A word or something you may have heard of, fetal PCA, may come up a lot. Or pardon me, this should be a fetal PCOM. And that's when that's a typo. So it should say fetal PCOM, but fetal PCOM is when the PCOM is actually larger than the P1 segment. And that's quite common. So another kind of image, I'll give you a second, second to get oriented or try to see what you try to sort it out maybe in your own mind. But if anybody wants to volunteer, they're certainly permitted to guess, but try to see what you see there and see if you can sort these out. So this is going to be basilar. So you're looking down. This is the brainstem here. These are the cerebral peduncles. You can see the substantia nigra, that black bit there. So you have here the basilar coming up. This is P1. So that post P1 segment. This is going to be P2 into the quadreminal segment. So this is the PCA coming back around the brainstem. This is going to be PCOM, so fetal PCOM. It's quite large, but that's, again, I know it may look a bit confusing, but if you really understand that schematic of the circle of Willis, you should be able to sort this out. Here are some of the venous structures to name. This will be the vein of Galen and the vein of Rosenthal. So number 3 is the vein of Rosenthal. Number 4 is the vein of Galen. Like I said, if this is all a bit confusing, this is all stuff that, I mean, not every medical student knows as they come through, but certainly this isn't stuff that isn't unreasonable to expect the 4th year student to have a pretty good idea of what, or to be able to sort out this anatomy. I'll brush through this. There's named segments for all these. So the superior cerebellar artery, anterior, or ICA, as well as pica, all have named segments. For the sake of time, we'll blast through these. They're all named based on their anatomical location. So pontomesencephalic, cerebellar, mesencephalic, cortical. So the key, or one of the ways to think about these, is they're all based on where the arteries actually run. And the last segment for each of them is the cortical segment. So the SCA starts in the pontomesencephalic junction. That's how you get there. ICA starts around the pons. So again, the anterior and lateral pontine. And pica starts around the medulla. So that's how you can kind of start to fill these out. And then they're just named on based off where they're run. And you can see that here. So it's from Lawton's textbook. But again, SCA, in this image, you can see the pontomesencephalic sections. So pontine and the mesencephalon, same thing here. So that's the second one, and then it runs to the cerebromesencephalic segment there. They're all named. I mean, I won't go through all these in detail. You can look at this. This is taken from Lawton. He wrote a paper describing these segments. But again, being able to name all segments for the SCA, ICA, and pica are certainly within expectation. Sure. Venous anatomy. So I think a lot of attention, especially as medical students, is spent on the arterial anatomy. Venous anatomy is certainly important as well. But again, it's not as well described or well taught. You can think of it as kind of the superficial structures as well as the deep system. So superficial or the deep drainage into the superficial veins. There's a lack of the difference between the arterial system, as I'm sure you know, there's lack of veins or a lack of valves within the venous system, and the walls are less muscular. The sinuses are the something you may have heard of are the cerebral sinuses. So they're actually between the two layers of the dura. So they're between the periosteal and meningeal layer, as described here. This again a classic picture. So I think again, like I was saying, a lot of people spend time on the arterial anatomy, but there's certainly a complex venous anatomy that you can see here. So if you take your time, maybe take a second or two, try to think yourself through this, or if you know any of these, and then we'll go through it. So one, it's going to be the vein of Trollard. So that's the largest anastomotic vein. Two, obviously the superior sagittal sinus. So three, this kind of deep one along the midline. So that's going to be inferior sagittal. Four, sigmoid. That's not the best picture. Five, straight. So the inferior sagittal to the straight sinus, which drains back to the torcula, which is seven. Here, the midline of the cerebellum is going to be the occipital sinus. Nine, so there's two anastomotic veins. There's the superior one, which is Trollard, and it drains into this lateral one, which is going to be Lebbe. So L for lateral. So Lebbe lateral. And that's along the lateral surface of the kind of tentorial, of the temporal lobe. Yeah, important name cortical vein. So you should have a familiarity of these. So Trollard is going to be the these named kind of large veins on the cortical surface you should be able to recognize. So kind of in the frontal region, it's going to be the Trollard. Lateral along the temporal lobe is going to be the vein of Lebbe. And then there's a large sylvian vein within the sylvian fissure. Let's get that for the sake of time. So here, yes, that's what was I going to show. So again, similar idea, just being able to recognize this anatomy on anatomical structures. So you may see this when you're doing craniotomies next year. As you rotate, or if you rotate through your electives, you'll see these kind of structures and you'll look at it and you're like, I don't know what is what, but if you think about it, midline is going to be superior sagittal sinus. Laterally here, so just behind the posterior or behind the central sulcus is this large anastomotic vein. So that's going to be Trollard. Three, again, that large vein laterally in the temporal lobe. So that's going to be Lebbe. And then four, I think that's the sigmoid sinus. So a lot of anatomy, it's a bit dry, but this is all stuff, again, like the more you look at it and looking at, I think, both the images as well as the dissections, it helps give a sense of them. And a lot of these you'll hear repeated and you'll be asked this a bunch. Somebody will be doing a craniotomy in maybe the temporal region and there'll be a huge vein on the surface and they're going to ask you what it is. So knowing that Lebbe is lateral and that it's in the temporal region, it's probably a pretty good guess. They're not going to ask you of some random small vein. It's going to be a large vein that they're going to point at, and it's going to be either Trollard, Lebbe, or one of the sinuses. So while we do that is, I think, especially before your electives, you kind of, it's helpful to get a sense of that basic anatomy. And it's, you have to understand it in detail because what you're going to see when you do your electives is you're going to see people in operative positions. So their heads are going to be rotated. They're not going to be straight on. You're going to see a small craniotomy or a small a hole. And then you're going to have to sort out, somebody's going to ask you, what's this? What's this artery? What's this vein? What's this nerve? And they're not going to be in that perfect picture from the textbook. The patient's going to be rotated and you're not going to be seeing the whole thing. And you're going to be asked to sort out what is this? And there's common approaches that you'll see. This was one of them, but why I emphasize this is it's really to be able in your head to kind of manipulate that 3D anatomy and manipulate the orientation to be able to sort out what you're seeing intraoperatively. So this is an approach, I'm sure you'll see it's kind of the workhorse approach of cranial neurosurgery, but it's called the pterigonal approach. And you'll see the head's tilted slightly this side, the head's tilted to the left, and you'll see a surgery or a craniotomy performed kind of in this region around the keyhole, and this is the trajectory that you get. This picture on the right of your screen is what you'll see. So you'll see the fish hooks applied. You'll see people take down the muscle, the temporalis. So again, another common question, what muscle are you operating on? That being the temporalis. And then you'll see people drill some burr holes there. So they take, this image shows what it looks like when the craniotomy's been done, the dura is opened, and then you're stuck with this view. And this is where somebody might point at one of these vessels and ask you what to do. What you're seeing, yeah. So we had our elective students, usually what we do. So for the electives is we'll do the craniotomy. The students will watch or help as needed. We'll drill off the sphenoid, kind of bring in the microscope, and then we'll get down there and start looking at some vessels, and we'll ask the medical students what's what. So this is kind of the view. So we're on the patient's right side here, and you're gonna, well, if you're the medical student, you'll be under, we'll bring you in to just have a look under the microscope, and I'll ask you, what are you looking at? So again, with anything, the key is sorting out where you are. So you have to find a structure you know, and the easiest one, I think, for some of these are the optic nerves. And you can see the optic nerves here. So there's one there coming back to the chiasm. So that orients you, right? So what runs beside the optic nerve is probably going to be the ICA. And what's this small nerve? So what, and again, it's complicated, but the more you look at it, the better it gets. But this is going to be the third nerve and running laterally. That's a membrane of Liliquis that you'll see cut, probably less likely. But again, it's looking at these schematics and learning them, because what you're going to see under the microscope is something a bit more like this, and your resident or the staff's going to point at some random vessel here and ask you what it is, and you're going to be a bit confused. So why show you this? Why I do that? Again, it's come back to this. So you've hopefully you know the circle of Willis, but then when you're under the microscope and everything's zoomed in, it's a bit trickier, right? So this is, again, circle of Willis anatomy that we'll go through, but it's the view that you actually see intraoperatively. So maybe take a second to see if you can figure out what any of these are. Again, it's from the right side. Yeah, that's carotid. So I'll go through this, but again, the carotid artery. So key relationship here, again, find the second nerve. Carotid's the big artery coming back. Diving deep is the PCOM. So your carotid's coming up here, and now it's branching. So one side's going medial, one side's going lateral. So the side going lateral is going to be the MCA, side coming medial, ACA. This is the basilar artery deep there. So this PCOM's running back the P1 segment, which you can't really see, which is connected to the basilar artery. So again, here you can see the basilar artery at the depth. Number 2, again, it's going to be the ICA, the carotid artery, so it's running up. So 3, you have to sort out what that is. That's going to be PCA, so coming out laterally. So again, you're seeing, it's a bit tricky, but you're not seeing the whole thing, but the, yeah. PCOM, this is one you won't really see the PCA, but you will see the PCOM, and that's going to be diving back deep into the field, connecting the carotid to the PCA. And here again, M1 and A1. So that's a view you'll see intraoperatively, and this is something where one would be expected, or hopefully would have a general sense of what you're looking at if you're looking under the scope and trying to get oriented. So that's kind of the workhorse. So this view here is from the Paterional, and it's kind of the workhorse view that you'll see during your electives. Another view, subfrontal. So this is a giant exposure. You won't see this whole thing, but again, this would be kind of the expanded subfrontal view. Maybe take a second, see if you can get yourself oriented to give you help here. So again, finding that the optic nerve, so you can see the optic nerve here and here, and it's coming back to the chiasm. So the eyes are going to be out here, kind of at the top of the screen. And anybody want to wager what number 1 is? So
is that the sorry, is that the carotid artery?
Yeah, right. Yeah. So that's, yeah, totally nice. There's the carotid. So what's number 2 then?
Would that be the MCA then? Branching
yeah,
off?
it is. Yeah. And 3.
Would that be like M2 then?
Yeah, totally. And then 4.
Now I'm getting a bit lost, to be honest.
Yeah, so if you think about, so ICA, L to the MCA. So this is kind of A1 probably here, and then coming back is going to be A2. It's probably like A3. The genio of the corpus callosum is going to be here. Does anybody know what this white thing is in the middle between the optic nerves?
The mammillary bodies?
No, I guess so. It's called the lamina terminalis. So it's just behind the optic chiasm. But yeah, nice. Good job. So I think seeing this and why we kind of hammer this, you go through it, you see it from different ways, and you start to get a sense of how everything looks. And I think for you guys and for medical students and for junior residents, just seeing this from different angles, different ways of looking at the same structures, it's never really a trick question, right? Like the questions like ICA, MCA, A1, A2, A3, whatever. There's not going to be like, no one's going to point at some random small vessel here and be like, what is this? You're like, I don't know, but you should be able to, if you get yourself oriented with the nerves or with the ICA, you can kind of, if you understand the circle of Willis, figure out the anatomy. Yeah, nice work. What's this? This is a bit trickier. The last one, I think this was the last, maybe one or two more approaches. Another approach you might see is something called the subtemporal approach. So the patient's head will be turned on the side like this. You'll take the bone flap down, you'll do a craniotomy like this. So you have this small kind of rectangular opening. The ear, you can see it's sketched here. So it's just going to be essentially a craniotomy just above the ear. What it allows you to do is retract this temporal pole, get along the floor of the middle fossa, and you can get to the posterior circulation. Yeah, so that's what I was highlighting here. So you can get to the posterior circulation. It'd be pretty rare to see this as medical students, so we won't spend too much time. But the key thing here is that if you retract the temporal lobe, you go along that floor of the middle fossa, so you get back to this posterior circulation. And it just highlights the relationship here again of the ocular motor nerve running between the superior cerebellar and posterior cerebellar artery. Again, like the question I've seen it asked hundreds of times. I've seen it asked a bunch. What nerve runs between the SCA and the PCA? And people struggle all the time. It's the third nerve. So just understanding that the third nerve runs between the SCA, PCA, it doesn't change. There was like taught in second year medical school, hasn't changed since then. Just know that relationship. And then that kind of, even if you're looking at this, you're like, what's what? You're like, well, this nerve is running between these two arteries that are coming out lateral. So probably the third nerve. That makes this probably the SCA, probably the PCA. Looks a lot trickier when you're looking at it operatively. I haven't looked at it. Oh, yeah, I haven't looked at this in a while. This is what it looks like. So knowing the schematics, one thing, then you're looking at this in the OR and you're like, what the heck am I looking at? So trying to figure out what's what, which was actually asked at a recent course. But if you're completely lost, you're like, find something you know. So there's this yellow structure, presumably a nerve, and it's running between this artery and this artery, right? So nerve between artery and artery. That's probably the ocular motor nerve. That makes this the SCA and this the PCA. You're kind of oriented there. So number one is going to be the SCA. This is a bit tricky, but number two is the basilar artery. So it's actually, everything's flipped, but it's this, oops, here. So basilar, SCA, PCA coming off the back. This is actually the PCOM segment, and this is going to be the ICA. So one SCA, two basilar, three PCOM, four ICA, five is PCA. I added these here just to, so if you guys do your electives next year, you've kind of seen some of the schematics, and all these images are available online, but I think they're good to look at before you show up to the OR so you have an idea of what you're doing. So this would be kind of a standard suboccipital craniectomy or craniotomy, which I'm sure you'll see during your rotations. So you take off a bit of the bone at the back of the head. Sometimes this is C1 or the posterior arch of C1. Sometimes it's removed, and you'll see this kind of Y-shaped dural opening. So that's kind of bonus points, but if you know that you open this posterior fossa dura and a Y, it's always good to hear. This is a bit complicated. I'll just go through this. This is the view you'll see here. Is some of the venous structures. So you can see here vein of Galen. So you're looking kind of straight back at the back of the head. This is just above the cerebellum, actually. Pardon me, above the cerebellum. 2 is going to be internal cerebral vein. 3 is going to be basal vein of Rosenthal. How do I add this here? Oh yeah, I added this. So this is the view if you're coming back. You're going to be just below the tent. So the tentorium is kind of at the top of the screen, and the cerebellum is being pushed down. So you're looking back at the kind of the pineal gland. So if you see any operations of the pineal gland, which is the structure here in the middle of the screen, this is the anatomy you'll see. That's a lot. Does anybody have any questions? If not, I'll just keep going. I'll do this stuff pretty quickly. This is just, I think it's something you may not see a lot of on your electives. You may see, if you go down to the interventional radiology suite, you may see a bit of this. I saw a bit when I was held in Dalhousie and a bit in London, I believe. I saw a bit of this kind of stuff. But just to familiarize it, so these are radiographs, so x-rays. There's a bunch of different views that you may hear. So PA or AP, Caldwell, Towns, Waters, there's a bunch of views that you don't really need to know. But these are all just different ways of orienting the skull when they take their x-rays. So again, the same way, it depends how you orient the x-ray machine. So the fluoroscopy when you're taking these views, so there's different views and it highlights different structures, but just to, if you're wondering when people are like saying Towns, Caldwell, PA, Waters, they're just different ways of angling the fluoroscopy or the biplane machine. This you may see, and this is where again it's coming back to kind of being able to sort out the schematic to the kind of real anatomy. For the sake of time, I'll kind of quickly go through this. But again, here, this is looking at the aortic arch. So this is going to be the innominate. So number 5 is the innominate or brachiocephalic trunk. The subclavian. Coming up here, this is going to be the ICA, and this is the vertebral artery. Contralaterally, this is the ICA. Common carotid, carotid bulb, vertebral artery coming off here. And it's the subclavian. I don't think I have those named. I won't paying you to go through all this again. But the key thing to highlight here is if you're ever lost looking at these, you're like, what the heck am I looking at it? If you're looking at the carotid, the key thing to differentiate is the external carotid or the ECA is the one with all the branches coming off. So you can see that here. So this one to the left has all these branches coming off. So the superior thyroid, like we talked about, superior thyroid, lingual, facial, ascending pharyngeal, IMAX, STA. So again, like some anatomists like freaking out poor medical students. You can sort that out. But if somebody's asking you what you're looking at, and usually for a medical student, we pretty much expect them to be able to figure out that the one with all the branches is the external carotid, and the one with no branches is the internal carotid. So if you're looking at this, this is mostly to show you the ECA, but again, looking at this, you're like, what the heck am I looking at? And you're like, I don't really know. The key is that there's all these branches, so it's probably external. And then you just have to go back to that, and I still do this, going back to that mnemonic of like some anatomists like freaking out poor medical students. So like superior thyroid, lingual, facial, occipital, ascending pharyngeal, where are we? Posterior auricular, superficial temporal, maxillary, and then middle meningeal. So knowing that mnemonic and being able to apply that here is helpful. This is what, for the sake of time, I won't belabor this, but this is again what angio of the MCA will look like, or pardon me, the ICA. So this is the ICA. This looks a bit more like the schematic. So I actually find these pretty easy to sort out, but this is, again, the ICA coming back here. You can see it coming across. So this is ACOM. These are the ACA branches. So ICA, the M1, M2, M3, M4, and these are the lenticular striates in the middle. This is what it looks like. And I put these up here just so you, if you're asked this, you can, I think these are easier than actually the operative anatomy because these look a lot like the textbooks, but there's no big trick here. So if you understand what they look like in the textbooks, you should be able to sort this out. Let's take a bit of time. This is, yeah, so the ACA. So again, there's no tricks here. So these are the colossal marginal, and this is going to be the pericallosal. But again, you can sort out here how the ACA comes back, and this will be recorded, so you can actually go and look at these pictures. But they do look a bit confusing at first. And I think if you've never seen this before, you're like, what are you looking at? But the key is to, again, find something you know. So this kind of like artery hooking back is always going to be the ACA, and that lets you get oriented and sort out pericallosal, colossal marginal, orbital frontal, the frontal polar branches. Same thing for the PCA. Let's skip that. How much time? Kind of for the sake of time, I'll blast through some of this. I'll just skip this. Belabor venous anatomy. This you don't need to. All right, helpful. This is a classic pimping question, so I'll stop here. But you'll see this big artery coming off the basilar. So this is the basilar trunk. Obviously, P1s are PCAs, which we talked about, and then the PCOMs are these cut arteries. But if you see somebody with a bilateral thalamic infarct, I mean, it's rare, but why it happens is that sometimes you can get this variant where there's a single thalamal perforator. So normally there's thalamal perforators coming off both PCAs or off both P1 segments. Sometimes they come off a single segment, so that being what it's called, it's named the artery of Percheron. But if you, I mean, this is a common question, knowing that if there's a single thalamal perforator, it's called the artery of Percheron. And that's how you get this kind of, if you get a stroke here, occlusion of this PCA, you'll see bilateral thalamic infarct. So the question being, how do you get bilateral thalamic infarcts with a unilateral PCA stroke? And it's because of an artery of Percheron. This I got asked this when I was in London on my elective. That embryology you probably thought you never have to know again for medical school comes up. So there's this is complicated stuff, the actual development, but there's essentially the anterior and posterior circulation connect through multiple anastomoses during the embryonic period. And there's 4 of them and they're all named. Does anybody know any of them? No one's like ever heard of these. So trigeminal, there's a trigeminal anastomosis, otic, hypoglossal, and prolantal. So man, I got asked this when I was in London. I was like, oh, I never heard of these. But there's 4 persistent kind of carotid, essentially carotid vertebral basilar anastomoses that you should know, or at least have heard of. So now you can't claim ignorance that you never even heard of these. So again, trigeminal, otic, hypoglossal, prolantal. They're named for where they are. The easy way of thinking of this is they're named for kind of where they are relative to the nerve. So trigeminal being around the trigeminal nerve, otic being around the 8th nerve, hypoglossal being around the 12th nerve, and prolantal being around C1. So they're all named relative to where they are. And you can look up this picture online and get this diagram. But yeah, I was asked this as a 4th year medical student to name all 4 of these. That's that. So that's kind of a whirlwind tour of introductory cerebrovascular anatomy. I think most of that stuff, almost all of that's pretty fair game for asking a 4th year medical student. Obviously, not everybody knows it, but certainly students who rotate with us and who've done this lecture, some people do tend to know it and can get stuff right. So I think for you guys, if any of this is new, that's totally fine, and it's good to hear about it, and then gives you a sense of what's kind of out there. But if you're going into your 4th year electives, I think it's just a good idea to refresh yourself on some of this basic kind of vascular anatomy, and it's good to show that you're reading and that you know the stuff. And yeah, I think the big step for you guys is coming from medical school, where you're going to see a lot of like schematic type diagrams. And then being able to apply that in vivo to patients, which involves kind of rotating, things don't look the same, it's messy, and that's a challenge. And I mean, it's hard, and it's obviously everybody understands it's challenging, but that's something that's the quicker you can pick that up, the better you'll be operatively. And the key to being able to do that is to understand it, that those kind of core principles, being able to draw the circle of Willis and knowing where things are relative to each other. And then once you know that, you can kind of manipulate it in your head when you're looking at the patient. I'll share this. So this was kind of how I ended last year, and I found it very helpful. But I think most people kind of here are going into their fourth year electives, and these are some tips that I think myself and some of the other residents have compiled over the years. And feel free to interrupt or ask questions. I don't mind. I think it makes it more entertaining than me just talking for an hour. But these are some of the kind of tips that I found helpful or that we've had over the years. So I think the first one, and I mean, we see this and we kind of ask everybody, and everybody's going to ask you, why do you want to be a neurosurgeon? That question is going to come up everywhere you go. But kind of being honest with yourself and knowing why you want to do it, I think it's a, or I don't think it is a very challenging specialty, and there's a high attrition rate, close to 30% in the specialty. And I think people sometimes maybe think it's glamorous or very academic, and at the end of the day, it's very, very hard work, and it's stressful work, and it's challenging work, and you have to be prepared for that. I think people who don't understand that or don't realize that struggle, especially early on in residency. And if you like whatever you like pathology, go and do pathology. Like there's no shame in doing something else. I think it's not a specialty that you want to do because you kind of like it. It's something you want to do because there's nothing else you'd rather do instead. And you'll hear this as you rotate through next year. The big one, and we were talking about electives before this started, but I think if you're interested in going to a certain university or program for residency, you should do an elective there. I know you guys only get, I guess, 8 weeks of electives total for neurosurgery, but I think you should do 2 probably at your home program and do the remainder of the 6 weeks elsewhere. You should go these are essentially a trial. I mean, there's 2 ways of viewing them. One, they indicate to a program you're interested in them. Like if you do all your electives in Ontario and then you apply to a Western Canadian school, they're going to think you don't want to come to Western Canada. That's just it's not very, it's pretty evident if you go to like Toronto, Western Mac, and Ottawa for your 4 electives, and you apply to a Western Canada school or to an Eastern Canada school, they're going to be like, well, you don't want to leave Ontario, right? It's pretty, people notice where you do electives. So I got asked everywhere I didn't do an elective, I got asked why I didn't do an elective there during my interview. So everybody understands you have a limited number, but if you're doing they suggest or they indicate which programs you're most interested in, right? That's how people see them. So yeah, like I said, everywhere I didn't do an elective, I was asked during my interview why I didn't. I did an elective in Calgary, and when I interviewed in Edmonton, they asked me why I didn't do an elective in Edmonton, why I went to Calgary instead. That was the interview question. So people do take it as a sign of interest. So what I did, or what I would suggest, is you pick your top 4 programs in Canada and do an elective there, wherever you can see yourself training. If you want to stay in Ontario, that's great. Do it for Ontario schools. But if you want to go to whatever Dal and Calgary or Sask, wherever you think program you're most interested in, you should try to do an elective there. And then I think with electives, they were on pause a bit for COVID for a few years, but they're certainly back. And I think they're approach them as a tryout. These are your elective performance is more valuable than any letter of reference you'll get or any research you'll publish. I kind of tell this to all the medical students that rotate through, but when you're at a program, look at the junior residents. If you come to BC and you hate me or like me, doesn't really matter because I'm going to be gone in a year. The Chiefs are gone, right? They're not going to stick around for your training. They're going to be 1 or 2 years left. But the junior residents will be there for the duration of your program or your training, as well as the staff. So really take time to get to know them and see what they're like. And if you really, when you're ranking programs, I thought more about what I thought about the junior residents and if I wanted to be their co-residents and what I thought about the Chiefs, because the Chiefs are going to be only there for a year or 2 of your training. This was something, we're seeing it more now. I think, again, with COVID, things were paused, but really maximizing your neurosurgery related electives. So there's a lot of peripheral neurosurgery electives you can do. So orthopedic spine, neurointerventional radiology, neuroradiology, ICU. And having those electives really shows a commitment to neurosurgery. And people will tell you different things, but I think if you have half your electives in plastic surgery and half your electives in neurosurgery, there's still going to be a question about your commitment to a field, and whether or not that's fair, that's another thing. But I think that's something that's, especially in the small competitive subspecialties, that's something that's persisted, is if you have a lot of weeks at some other specialty, how committed you truly are to a given specialty. Solicit advice broadly. So that's to say, don't just listen to me, but go and talk to a bunch of people and get their opinion on how you can maximize and succeed during your electives. Everybody's going to have their own 2 cents. I guess the last one here, fit's important. I think a lot of people rank programs based on perceived prestige or what they're told about the program, but you're going to spend a lot of time at a given school, 6 to 10 years, depending on where you train. When you're ranking, I think the best thing to do is be honest with yourself and see how you fit within that program, and think about that when you rank. So don't just rank on prestige, but truly see how you fit in that program. And I think the people who do well are those that match to a program they fit in well at. That's it. Does anybody have any questions?